So thank you first for inviting me. I have no disclosures, but I am very grateful to be part of this initiative, and thank you, Ikro and Lorenzo, for inviting me, and thank you so much for your hospitality. And I think we all agree, and this is the final consensus regarding radiation therapy, 100% consensus that we need to do better in clinical trials. We don't have data. And I'm thankful for my task force group. A lot of people contributed to this presentation with regards to the recommendation that we're gonna make. So our task force was aimed to develop minimal requirements for recording radiation-related parameter in clinical trials. And I would like to emphasize this nice publication. If you have the time, look at the full PDF. It's about phase 4 trials, and it has a few very known drugs just showing or proving a point that we have a very competitive and very a pressure process for having clinical trials that require short development times and publication, and often these are suboptimal for our patients in the clinical use. And we are left with unanswered questions because our obligation to the patient, that day-to-day use of those new development will be safe for the patients. And this is the same criticism I have for local regional prospective trials. It's the same. So the successful registration of a new medication, it's not the end of the drug development. We need to know exactly what happens in real life. And this is actually why we're all here, because we want to improve the future trials, prospective data set, facilitate national and international collaboration, and provide these essential data to our patients. And this is a photograph that I took when I was a clinical fellow at the University of North Carolina. David Brizel came to give a talk, and this is exactly reflects what happens in real life. We have the ivory tower, which is the early phase trials, and we have what happens in real life. We have high toxicity rate and low efficacy. So we all, with regards to radiation, know that there is a relationship between the radiation dose and radiation volume, including breast, great publication by the Danish Breast Cancer Group recently, to normal tissue toxicity, and with regards to the risk of toxicity. So this is why we have guidelines and recommend dose limits for normal tissue. We know that we have new techniques in radiation to reduce these toxicity, but this mandates understanding, because it's not an error-proof approach, and we can have even add a lot of risk to the patients if we don't understand the technology. Radiation-related toxicity is a complex issue to study. Side effects are multifactorial, including intrinsic unknown factors. Toxicity can occur at different time points, including years after. So it is highly dependent on how you report, how you document, and if you follow up the patients. If you don't follow up, or you have poor documentation, you will have no toxicity. That I can promise you. And this is a common problem in clinical trial. And sometimes you have false causability, and this was nicely, David Dole had a great talk at the ESTROT course about sometimes we relate falsely toxicity to a certain situation. So as I indicated, this was our task, but I can say that what we're going to discuss soon is valid also for local regional trials, because many of the local regional trials do not report radiation or do not document radiation properly. This is a common problem that we see when we review papers to be published in journals. And these are some examples from local regional trials. I will not go into depth into all of them, but the Z11 trial, we all know the problem with the radiation in that trial. Radiation was defined in the protocol. It aimed not to give radiation to the lymph nodes, but yet the compliance with the protocol was pretty poor. So in my perspective, we do not know the impact of radiation on disease outcome on these population. And I am familiar with the Memorial Sloan Kettering following all sorts of cohorts in the purpose of defining this point, but I disagree. We still don't know. Similar problem with the Synodor 1 trial, and a new problem we have with the sound study. I'm sorry, it's nice that we don't have to do a sentinel lymph node biopsy to those patients, but the radiation is not documented. And if you look at the previous publication by Oreste Gelantini, you can see that actually the incidental dose of the tangential fields matter to those patients and reduces local regional recurrences. And how about the URTC-IMN trial? So this is a good example of central quality assurance for data collection and radiation, even though the trial was very permissive with regards to the local regional treatments that was not evaluated as part of the trial question due to a central data control for quality assurance of the data itself and the radiation. We were able to do subset analysis. Of course, there is problems with that because the number of events is low and the study the analysis was not powered, so we cannot have firm conclusion, but I would say that we had an hypothesis generating of good data. So much is published about clinical trials, radiation quality assurance. Quality assurance matters not only for radiation-related toxicity, but it can lead to significant morbidity and mortality, but it also matters for disease outcome. And we have data in breast cancer. Third of the sites had major deviation when they underwent quality assurance. Third, this is quite disturbing. And these major deviations matter for patient outcome. And assuming that those sites that participate in prospective clinical trials are the most advanced sites, those who have an infrastructure to perform in a prospective clinical trials, those who have a correct workload, expertise, having third major of the patient have third major deviation, for me it's quite alerting. And this is a nice example of how much radiation quality assurance impact the outcome of patients. This is in head and neck cancer. This is the time to local regional failure by deviation status. And you can nicely see those who were compliant with the protocol had better with regards to local failure. Those who were non-compliant but improved also did significantly better. So this is why quality assurance make significant outcomes for our patient. And the same graph is true about overall survival by deviation status. So breast cancer is not head and neck. This is what my colleagues would say. You can manage with 2D. Really? So this is something that we published with the Estro faculty. This is a patient who underwent axial lymph node dissection, And what you can see here is the dose distribution in the traditional suprafields after axial lymph node dissection. But look where she recurred, because you can nicely see the clips from where the axial lymph node dissection ended. And you can see that there was no dose in an area of level 2 where the patient recurred. So we need to delineate. We need to understand the volumes. So even though we have trials proving that central radiation quality assurance is important, it is always a struggle. I'm a member of the radiation quality assurance of the URTC. We always need to convince that our job is important for the outcome of the trial. And assuming those sites are the advanced ones, this is alerting. So mainly is because these are data from clinical trials. What is going on in the sites or centers that adopting these radiation techniques? When we have quality assurance centralized, these are the so-called deviation we have. This is kind of scary. So for breast radiation, the proximity of the breast, chest wall, and regional lymph node irradiation, especially internal mammary, we are close to critical organs at risk, like the lung and hearts. There are some indication for breast cancer radiation that actually the therapeutic window is marginal. So any error in radiation, we're losing the benefit. And studies or trials that included protocol for radiation quality assurance were pioneers, actually, in demonstrating improvement in radiation. And this is exactly why. And this will be shown in the new publication of the EBCTC G meta-analysis that it's going to be published soon in the Lancet Oncology, showing that modern radiation therapy for breast cancer makes a difference. So the optimal requirement is central quality assurance for trial, but we need essential requirements, minimal requirements, so they can be implemented in all the centers. And this is for daily use and also for reporting outcomes. And much effort is already ongoing by different national and international societies, because our oath is not to harm the patients. And if we increase toxicity, please report and record so we'll know. So the first step, let's eliminate the physician preference from studies or reporting. We need to decide on guidelines. We don't need to invent one. And we know this is a problem. When you read the NSABP trial for primary systemic therapy, you don't understand what to do with the radiation. We lost important data due to physician preference. And just a small note, they even noted that in a prospective trial, they had disparity of care. So this is kind of a problem. So with regards to target volume and organ at risk delineation, you need to decide on guidelines. No need to invent one because we already have. And you can take courses and perform peer review for delineation. Because if you delineate, it doesn't mean that you delineate correctly. This is an example for delineation according to the bony landmarks. So delineation needs practice. You have online courses, for example, the Falcon course, and you see there is variability between the participants. And you need to understand the anatomy, and this is what we show from the Amaros trial. This is why they had significant toxicity in the radiotherapy arm, even though they didn't have axial lymph node dissection. When you include the lymphatic from the arm in your field, you'll have more lymphedema. So please delineate even if you don't plan to irradiate the nodes, because in tangential field, it will give us input about the incidental dose to level 1 if we want to conclude about omitting a sentinel. Because for me, if we want to truly de-escalate, or maybe what Charles said, optimize therapy, I do not want to compensate by radiation because of uncertainty of data that was not reported. And if you want to learn how to delineate, you have a nice video, and actually I looked for a photograph. You look like a superstar here, like in Hollywood. So Birgit made, so you have a free online from Falcon. I'm out of time, but we have the, as usual, we have the RAPChem trial, which is a nice de-escalation for radiation out after primary systemic therapy, and they reduced the radiation volumes. They had quite a lot of patients. And what nice is that they reported, according to the stratification of the groups, the local regional recurrences. But what more important in that trial, that they even reported the compliance with the radiation protocol according to the risk group and indicated the recurrences. And this is amazing because you see the, I don't know if this is a sort of physician bias, because the low risk group were actually younger, more triple negative. They had more deviation in including more volume. So when you read this paper, the author give you tools to understand the outcome and decide for yourself. So decide on the guidelines also about fractionation. In my view, 15 fraction is moderate hyperfractionation, but it's not isotoxic to 16 fractions. So please don't do one patient like this and the other one like this. If you have a clinical trial, mind the boost. We know that breast toxicity is related to dose volume effect, but we also showed that quality assurance, if you have centralized quality assurance, you can actually analyze those data. Have objective, don't invent, decide on guidelines, and you can look at the trials that were already published and use those constraints. You don't need to invent one. And when you adopt constraints, see if they're valid to your protocol. And this, we do not know how technique influence, and we spoke about microenvironment, we spoke about induction, the lung environment in immune check inhibitor. We don't know if the tangential field work the same as a more, when you use an arc. We don't know about efficacy nor toxicity when we combine in drugs. So I'm afraid I have to start finishing the presentation because I'm really over time. Do you want, or okay. I can go on? Okay. So this is about helical tomotherapy that we reported from the UNC experience. And as you see, the lung V20 was pretty okay when you have bilateral breast. But when you see the planning here and the actual doses that the patient exposed using tomotherapy, this is quite disturbing. And when we looked at the toxicity, we had events of pneumonitis, and this specific patient had even hepatitis due to radiation toxicity. So this is quite disturbing. So it's very simple how to avoid toxicity. As I indicated before, if you don't follow up the patient, you don't have toxicity. If you don't record it, you don't have toxicity. And if you use incorrect scales, because like if you use the breast-Q or something like that as prompts, you won't record the toxicity. So we're treating cancer. It's obvious that we'll have toxicity. It's okay. Nothing happens as long as we report it. And then we have tools to decide if we want to use it. And harmonization, can be performed without jeopardizing the ability to individualize therapy. So there are a lot of ways to facilitate quality assurance, and this will give us also data for automatic AI-based quality assurance procedures, record using the CTC AE because it's a good method and it's very broad, and see other groups' important initiative like the NABON initiative for harmonization. And this is the Canto RT, which is a blessed initiative in France, I think. Take a look at the publication. Thank you.